komitmen kami untuk terus meningkatkan pemahaman dan tata laksana pasien kritis dengan AKI, di mana CRRT memainkan peran penting. Bersama narasumber yang telah bergabung pada siang hari ini, kita akan menggali lebih dalam protokol terbaru, bukti klinis, dan tantangan dalam penggunaan CRRT, termasuk antikoagulansi regional sitrat yang telah menjadi standar. Sebelum saya mulai, saya ingin mengingatkan bahwa webinar ini bersifat edukatif dan keputusan klinis tetap menjadi tanggung jawab masing-masing tenaga kesehatan. Mari manfaatkan sesi ini untuk berdiskusi aktif dan berbagi pengalaman. Pada siang hari ini kita akan memiliki beberapa topik. Yang pertama adalah opening remarks dari Dr. Erwin Pradian, SPANTI, SubsTI, SubsANR, MKes sebagai Ketua dari Asosiasi Perdici. Kepada Dr. Erwin Pradian dipersilahkan.
Ya, terima kasih, Mega. Bismillahirrahmanirrahim. Pada yang terhormat sejawat guru besar dimanapun Anda berada, kemudian kepada sejawat-sejawat dokter dimanapun Anda berada, Bapak Ibu yang saya hormati, pertama-tama marilah kita panjatkan puji dan syukur kehadirat Ilahi yang atas berkah dan rahmatnya kita dapat berkumpul pada siang ini dalam kondisi sehat walafiat. Pada kesempatan ini, sebetulnya ini adalah acara webinar serial yang sebelumnya pernah kita laksanakan dengan topik khusus tentang continuous renal replacement therapy. Dan pada siang ini kita akan membahas mengenai antikoagulan sitrat ya yang kita gunakan untuk CRRT. Jadi nanti para expert ini akan menyampaikan mengapa harus menggunakan sitrat, mengapa Kadiku merekomendasikan sitrat sebagai antikoagulan, apa untung ruginya, serta bagaimana monitor dan lain sebagainya. Untuk itu saya ingin menyapa dulu para pembicaranya ya. So I would like to thanks to our distinguished speakers today, Dr. Albert Xiaofu from Hong Kong, Dr. Robert Paul Meyer from German, and also Dr. Bambang Pujo from Erlangga University. Thank you for sharing your knowledge and experience with us. It truly means a lot, and this will be of great value to us. And also, I would like to thanks to Fresenius Medical Care for your support in making this event possible. Terima kasih. Sekian saya ucapkan selamat mengikuti acara webinar ini. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih kepada Dr. Erwin Pradian atas sambutannya. Tanpa berlama-lama kita akan melanjutkan kepada topik selanjutnya yang akan dibawakan oleh Dr. Albert Xiaofu, MD PhD. Before we start, Dr. Albert Fu, I will introduce you to the participants, to the attendees in Bahasa Indonesia. Jadi Dr. Albert Xiaofu, MD PhD merupakan Director Asia Pacific Global Medical Information dan Education, Fresenius Medical Care Asia Pacific Limited, Hong Kong. Beliau telah mengenyam beberapa pendidikan. Yang pertama merupakan Bachelor of Medicine pada Clinical Medicine Huazhong University of Science and Technology Wuhan, China. Kemudian dilanjutkan sebagai Master of Medicine in Nephrology Huazhong University of Science and Technology Wuhan, China. Kemudian beliau juga mengenyam Doctor of Medicine di Albert Ludwigs University Freiburg, Germany, dan Master of Arts in Religious Studies, the Chinese University of Hong Kong, Hong Kong, dan juga Doctor of Philosophy in Religious Studies, the Chinese University of Hong Kong, di Hong Kong. Without further ado, please join me in welcoming Dr. Albert Xiaofu to begin the presentation. For Dr. Albert Xiaofu,
Thank you so much,
starting.
Magna, and also Chairman. Um, appreciate the invitation to share my experience and knowledge about regional citrate anticoagulation. And thank you for the audience also taking the time during your weekend to listen to this sharing together with the other speakers. I hope you can see my screen now. Yeah, thank you. So today's main discussion from my side is to share different solutions as well as different protocols used for regional citrate anticoagulation. Just very quickly about the disclosure. I'm the Director of Medical Information Education, Global Medical Office, Fresenius Medical Care Asia Pacific. This content is to try my best to provide data to assist your own decision making, but it's not to replace your judgment and clinical experience to manage your patients. So as mentioned by the chairman as well as the moderator, the content I will cover in mainly two sessions. One is about available solutions. They might have a lot of difference to be used for RCA. The second part is more focusing on the comparison of RCA protocols using either concentrated or diluted citrates. I tried my best to extract the newest data available to share with you what we can find from those. So to start with, even we had a previous version to talk about basics as well as the CCAR protocol in detail last session in February, but here just one slide very quickly goes through the general concept, how RCA will be working in CKRT. We call it regional because it's really work only in terms of anticoagulation, only in the extracorporeal circuit. Citrate will be infused into the circuit very quickly as the blood from the patient into the circuit. And this will lead to the dramatically reducing of the concentration of ionized calcium in the circuit. Normally, the target can be different depending on the doctor's preference. However, very commonly, it could be expected to have a target of post-filter ionized calcium in the range of 0.3 millimole per liter. And we can also imagine this, for example, citrate calcium complex will be partially removed depending on the CKRT dose. If the dose is quite large, maybe majority of those could also be removed. But in general, the CKRT dose recommended by KDIGO, we might remove, for example, half of the complex from the circuit. That's the reason why we need calcium infusion back to the patient to restore the systemic ionized calcium in the normal range. And also to bear in mind, this 0.3 would never be experienced in the systemic level because even as low as 0.8 or lower, the patient would already experience a very life-threatening arrhythmia to have a very dangerous situation. So that's never reduced to the level to have anticoagulation effect systemically. So it's really regional. So recommended by KDIGO, even that is more than 10 years ago, but very clearly, for example, for the patient without increased bleeding risk, normally we might use heparin, but the international guidelines suggest using citrate as long as the patients do not have contraindication for citrate. In case the patient have increased bleeding risk, the common practice might be not using any anticoagulation, but according to guideline, citrate would be considered and suggested as long as the patient without contraindication to citrate. And after 2012, actually, quite some more data available. Here I listed reference 1, 4, and 5, and there are more actually available meta-analysis. And also reference 2 is the up to date, the biggest RCT to compare RCA to systemic heparin used. All of them showing two major benefits. One is reduce the bleeding risk. Second is a significant longer filter patency comparing to heparin used for CKD patients. And additional benefits we can imagine whenever the filter lifespan is prolonged, this could also be translated into reduced downtime, which eventually will also translate it to potentially reduce the nursing workload. And also we can imagine more efficient anticoagulation will also have more reliable achieved target of CKRT dose. We know that prescribed not always 100% achieved. So this will also ensure we are closer to the prescribed CKRT dose. Now we dive into details of what are the major different solutions used for RCA. I will mainly introduce three types, one starting from the citrate. This might be one of the major difference. For example, normally people will call it either concentrated or diluted, normally in terms of the sodium concentration, whether or not that is isotonic, then it might be having very similar to our healthy population sodium level, or if that is concentrated, the sodium level might be much higher than the physiological levels, can be 400, can be 200. And in terms of citrates, I listed here as well, although some of them may come in only from trisodium citrate, but some others may also have citrate coming from citric acid. So anyway, the concentration for citrates as the active component to support anticoagulation, the concentration would be in the range of around 100 or 136, or can be diluted as low as 12 or 18. And this sodium level will be important here because the later dialysate sodium level might be also adjusted to compensate and mitigate potential risk of electrolyte disbalance. But at the end, we can also see that the volume in the package can also look very different for citrate. 4%, for example, the commonly available might be 1,000 or 1,500 milliliter. And for diluted, it can be 5,000. Even their volume is much bigger, you can also easily calculate the potential back exchange frequency might still be quite different in terms of using 4%. The frequency of a changing citrate back can be still much less comparing to this very diluted citrate solution. So we will touch this later. This is also part of the differences comparing to different protocols. The second solution we are talking about will be dialysate. We talked about the sodium in the concentrated solution will be high so that in the dialysate, sodium level will be generally lower than physiological levels to compensate, to mitigate the disorder. And for the diluted citrate used, their dialysate sodium level generally would be the normal range. All of them prefer to use a calcium-free that will achieve the best anticoagulation efficacy. Magnesium sometimes would be increased to compensate as well because citrate not only binds to calcium but also can bind to magnesium, which in the long run still can lead to deficiency. So sometimes concentration is a little bit increased comparing to general CRT solutions. Chloride, as you can see, majority still in the range close to the physiological range, but bicarbonate, for example, we see majority of them might use reduced because citrates, as we mentioned, part of them can be infused back to the patient. That work also as a buffer. So at the end, we might not need typically like above 30, but reduced buffer coming from bicarbonate, because partially it will be also offered by citrate directly. Lactate, some of the solutions also have a small amount of lactate. Some doctors might be a little bit concerned whether liver failure patients might even have additional burden for the liver to metabolize this. So it's really depending on clinical judgment whether want to use purely without lactate or some lactate to be tolerated. If the filter life is long, the CRT can also run several days or even weeks. So phosphate level, if that is to prevent hypophosphatemia, and some solutions also contains phosphate. So lastly, for the solution difference is the replacement fluids. Generally, they were given, for example, post-filter, so that they will contain calcium, but don't have a huge worry about impacting the filter lifespan, because this is already post-filter. And also the other electrolytes would be simply the same as the solution used for heparin CKRT. I just mentioned also lactate and potentially phosphate in some of the solutions. So I hope that gave us a good impression what kind of different solutions will be used. And then we move to the different protocols using concentrated and diluted citrate. This is a very quick overview. We know already the component might be different, but beyond that, what's different in the protocols? For example, the bags we mentioned already, the initial dose of citrates, minimal per liter blood, will be also potentially different according to different protocols. For example, the concentrated RCA protocols, it commonly can be 4, or if that is the CVVHDF to be prescribed, can be 5. But for example, CVVH or using diluted citrates, in their existing established protocol, they might have just 3 as the initial dose for citrates. And we know that the concentration will be very different. So very naturally, the infusion rate pre-filter will be also very different. In 1 hour, for the concentrated, might only need around 200, but for the diluted, they might simply easily need 1,500 fluids. Even this is not intended to be used for convection, but still this large pre-filter fluid given eventually would contribute to CKRT efficacy. So later we will also talk about this will impact whenever we want to adjust the anticoagulation efficacy, we might want to change the flow rate or concentration of citrates. But then if this is diluted solution, dramatic change might be needed if to the pre-dilution. This will impact the CKRT dose eventually as well. Blood flow rates, generally for concentrated, we prefer to have lower, like 100, but for the convective-based protocols, they normally prefer a little bit higher so that the filtration fraction wouldn't be too high to have hemoconcentration in the filter. Dialyte flow rates, there is another concept. Generally, in this protocol, the ratio we can see is roughly 20 to 1. So more dialysate would be used, but in the diluted citrate protocol, this ratio of the dialysate to the blood flow rates is generally 10 to 1. So this roughly indicates how dominant the removal of the toxins will be driven by diffusion or convection. So to summarize, the major difference of the protocols would be citrate dose, citrate concentration, and also whether or not significant the pre-dilution. And this will also impact whether significant linkage of the citrate dose adjustments to impact the CKRT dose. And also we can see diffusion-based modality or convection-based modality. Blood flow rate different, and the ratio of dialysate to blood flow rates is generally also quite different. But they share a lot of similar principle and also solution used, like dialysate calcium-free and calcium-containing for replacement fluid. Now we can dive into the studies. Before we dive into really concentrated to diluted, we can start from different concentrations, but still both of them can be understood as diluted solutions. There might be some signal already based on the previous studies. This is one study from Australia. Both groups are using CVVH, and the citrate concentration slightly different, 11 and 14. And the filter lifespan eventually have 5 hours difference significantly. And the post-filter RNAs calcium in the longer filter lives group has lower post-filter RNAs calcium. The authors believe the major difference coming from where? Coming from potentially higher citrate concentration, as well as different blood flow rates. So for this group, they use 200. For this group, they use QB 150. And more importantly, citrate systemic ionized calcium target is different. So in the second group, they have a little bit lower ionized calcium targets. So this is the first study we introduce now to see some potential difference if we use different concentrations. The other study from Belgium, 10 years later, similar patient number, also using CVVH, and the concentration of the different citrate group is 12 or 18. And we can see they also observe significant difference in terms of filter life. One is almost 2 days and a half, and the other more than 4 days filter life. And apart from that, they also observe lower TMP in the group using a little bit higher concentration of citrate. And they believe this high concentration will lead to less clogging and the protein cake formation will be reduced. Eventually, different comparing to the previous study, they didn't observe any difference in terms of post-filter ionized calcium. So more importantly, now we dive into the major 3 studies in Switzerland, Spain, and Thailand. They are exactly comparing the concentrated and the diluted citrates. So the first one from Switzerland, they are comparing concentrated citrate CVVHD to the diluted citrate CVVH. And we can see from their results, we see similarly longer filter lifespan for the more concentrated group. However, they see additional information, for example, higher total cost for this concentrated group. But if they calculate that into per hour cost would be similar to the 2 groups. And they also observe a higher number of adjustments of the anticoagulation in the concentrated group. More efficient toxin removal observed also in the more concentrated group comparing to the diluted groups if we look at urea and the creatinine reduction ratio. Finally, the other negative finding for concentrated protocol is a higher alkalosis incident in the more concentrated groups. How about from Spain? This is actually a little bit different protocol. They adjusted to make it less risky for the clinical staff to switch different protocols. They find, well, some is convective, some is diffusive. They made some adjustment. For example, citrate dose, they made the citrate dose initial for both group 3.5. This is different to the original protocol, either 4 or 3. This make it more comparable for the staff to follow. The other major difference deviating from the original protocol is for the diluted solution and the protocol, they do not use post-filter replacements. So make these two protocols almost very similar is diffusive driven. We call both of them CVVHD. So again, even they made modifications, the results quite similar, longer filter lifespan for the concentrated citrate group. If we count the filter lasting longer than 48 hours, 3/4 in the concentrated achieved that, but only half in the diluted group achieved 2 days filter lifespan. A little bit trend towards alkalosis, but not statistically significant. More importantly, they observed the need of electrolyte replacements much more needed for the diluted group. They explained some of the reasons. For example, not using post-filter replacement fluids might reduce their efficiency to mitigate electrolyte disbalance issues, but there are the other reasons listed. I just skip due to the time limitation. So the final study, very fresh, published in June this year, is coming from Thailand. They didn't deviate from the original protocols too much. So for CCA and concentrated protocol, either HD or CVV-HDF, but for the diluted protocol, CVVH is the very traditional modality. They also didn't modify the citrate dose, initial dose, simply follow the protocol suggestion. And they look at the so-called premature clotting and more than 100 filter eventually into the final analysis. The results very similar to the previous studies, concentrated RCA protocols lead to more filter last longer than 3 days. Just to mention, this might not be in-label use, but this is depending on the doctor's decision. But much less in the premature clotting group means more concentrated, longer filter lifespan. And they also did additional analysis. So this is very significantly associated to the isotonic citrates in terms of premature filter clotting. Filter clotting will also be having higher risk if lower citrate dose is used. We know that diluted protocol use concentrations 3 and concentrated protocol using concentration either 4 or 5. So complications largely comparable. So to summarize, RCA is generally safe and efficient, recommended by KDIGO as the first line for AKI patient requiring CKRT as long as there is no citrate contraindication. Component of the commercially available citrate solutions can vary, especially in terms of citrate concentration, concentrated or diluted, and dialysates. Majority of them using calcium-free and replacement solutions. Commonly, they use calcium containing. And different protocols differ in different perspective beyond this solution composition. Additional major difference, for example, initial citrate dose, 3 or 4 or 5, and any significant pre-dilution. This is especially significant in the diluted protocols, and whether or not citrate dose adjustment will link to a dramatic change of CKRT dose. And finally, we see a strong signal, even the clinical data is still limited. We see that concentrated protocols potentially might be associated to longer filter lifespan. Allow me just 3 lines to summarize their argument why they believe this is the case. One of them is talking about high concentration lead to lower TMP because lower risk of clogging and protein cake formation on the membrane. The other reason provided from the Spain study, they believe that less frequent back exchange of either citrate back exchange or calcium back exchange will also improve the lifespan for the concentrated systems. And finally, the protocol using different citrate dose as well as diffusive versus convection dominant CKRT modality could also play a major role whether or not concentrated can lead to longer filter lifespan. I will stop here and hope you have any question now or later to be discussed.
All right, thank you so much, Dr. Albert Fu, for the presentation. We have several questions in the question box. Perhaps we will answer it like directly for 3 questions first. The first one is, hello, I'm Rico from Solo. I want to ask to you what kind of RCA that we can use for CKRT? Why we should choose citrate? What is the benefit using citrate? Thank you.
Okay, so as 2 of my slides mentioned, if we comparing this citrate use to heparin use, the 2 major benefits, one is a much prolonged filter lifespan. From different study may be different, but generally we often see the difference would be 15 hours difference. So that is one of the major benefit. The other is much lower bleeding risk. Even we observe still some bleeding in the citrate group. As I mentioned, citrate really work only in the extracorporeal circuits. Systemically, there would not have any anticoagulation effect. So the bleeding, even in this group, would be rather baseline underlying disease, but not really caused by citrate. These are the 2 major benefits, but additional benefits we mentioned also on the slides. Yeah, thank you.
All right. The next is, good afternoon. I'm Wahyu from Surakarta. I would like to ask, in the implementation of CRRT with RCA, what is the strategy for calcium administration? Please explain the role of calcium infusion and how it is adjusted based on laboratorial result.
Okay. Please allow me go back to one major slide to easily explain that. This slide. Okay. So monitoring ionized calcium has 2 positions. So one of the ionized calcium to be monitored is the post-filter ionized calcium. This is to check whether anticoagulation in the extracorporeal circuit is sufficient, checking whether anticoagulation is enough. And the other ionized calcium to be measured is systemic in the patient level. So this is to make the treatment safe to the patient. And we have both targets value for these 2 measurements. If this, for example, post-filter ionized calcium is not in the expected range, then we need to change the citrate infusion rate or dose to adjust the efficacy of the anticoagulation in the extracorporeal circuits. And this is linked. Whenever this target is not met, we need to change the citrate. On the other hand, if we see the systemic ionized calcium is not in the expected range, that means how much calcium to be infused to the patient would be needed to adjust. So these are the major difference between these 2 different ionized calcium, and why they are different, because one is indicating efficacy of the anticoagulation, the other is to indicate the safety for the patient. I hope that this simply answered the question, but feel free to reach out to me if still not yet.
All right. I think sufficient for Q&A for your session. Your expertise has provided invaluable knowledge that we will greatly benefit our clinical practice. So we will move to the next topic. The next topic is cash sharing. For for Dr. Bambang Pujo. Oke, em, jadi topik berikutnya akan dibawakan oleh Dr. Bambang Pujo Sumedi, SPANTI, Subs TIK, Subs Anestesi Pediatrik. Beliau merupakan head dari Anestesiologi dan Reanimasi Departemen Faculty of Medicine Universitas Airlangga dan juga Lecturer in Anesthesiology and Intensive Therapy Faculty of Medicine Universitas Airlangga dan juga Dr. Sutomo General Hospital. Dr. Bambang Pujo juga merupakan staf dari Anestesiologi dan Reanimation Medical Unit Dr. Sutomo General Hospital, juga merupakan ICU staff Dr. Sutomo General Hospital Surabaya dari tahun 2006 hingga sekarang. Pendidikan dari Dr. Bambang Pujo merupakan medical doctor, lulusan medical doctor dari Universitas Airlangga Surabaya. Beliau juga mengenyam sebagai spesialis anestesiologi Universitas Airlangga Surabaya dan juga konsultan di Intensive Care Universitas Airlangga Surabaya. Dr. Bambang Pujo juga mengenyam pendidikan sebagai doctoral degree di Universitas Airlangga Surabaya dan subspesialis pada pediatric anesthesiology Universitas Airlangga Surabaya. Kepada Dr. Bambang Pujo, waktu dan tempat saya persilahkan. Oke, sepertinya ada technical issue. There is a technical issue for Dr. Bambang Pujo. So we will next to topic first. Selamat siang, Dok. Okay, we will wait. So, Dr. Robert,
Ya, apakah bisa didengar suara saya?
oh, bisa, Dok. Oke, akan
Bisa ya?
dilanjutkan oleh Dr. Bambang Pujo. Baik, Dok, waktu dan tempat dipersilakan.
Ya. Baik, saya share screen ya.
Baik, Dok.
Apakah bisa terlihat?
Sudah, Dok, sudah terlihat.
Baik, terima kasih. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Eh, pada siang hari ini saya akan bicara dalam bahasa Indonesia ya, karena mungkin supaya lebih ini ya, lebih apa paham gitu ya, karena ini memang adalah hal yang agak sulit ya, karena kita seringkali kita tidak familiar dengan penggunaan sitrat untuk antikoagulasi pada renal replacement therapy. Baik, saya akan mungkin tidak akan terlalu lama ya. Ini adalah salah satu kasus yang eh, saya pernah kita tangani di Rumah Sakit Dr. Sutomo. Kita sendiri sebenarnya juga tidak mempunyai banyak kasus ya yang menggunakan sitrat ya, karena memang ini alatnya juga tergolong masih baru dan pengalaman kita juga belum terlalu banyak. Tapi saya akan mencoba untuk sharing pada kesempatan kali ini. Baik, jadi ini ada satu pasien ya sebagai overview ya, seorang pasien usia laki-laki usia 75 tahun. Dia awalnya pasien ini dengan morbid obese yang kemudian pada saat karena dia sudah lama sakit di rumah sakit ya, kemudian berat badannya turun dari 100 lebih jadi 80 kilogram. Tinggi badannya 175. Ya, pada saat dia masuk ke ICU, diagnosis utamanya adalah septic shock karena lower extremity cellulitis. Jadi dia ada selulitis yang cukup luas di ekstremitas bawah. Kemudian diagnosis yang lain ya, secondary diagnosisnya adalah pasien ini dengan akut kidney injury ya, pada dia juga dengan CKD, jadi dia adalah akut on chronic ya sebenarnya kidney disease. Pasiennya masuk dengan hiperkalemia, diabetes ya, komorbidnya dan dia dengan hypertensive heart disease. Nah, ini saat masuk ICU, diagnosisnya ini ya, dasar diagnosis dari akut kidney injury-nya adalah karena dia oligurik, punya 248, kreatinnya 13, adanya metabolic acidosis, kemudian pasien juga dengan hiperkalemia. Ya, dan metabolic acidosisnya ini karena sudah mulai acidosis berarti sebenarnya dia sudah impending respiratory fatigue. Nah, selanjutnya yang kita lakukan ya karena dia sudah mulai dekompensasi, maka kemudian pasien dilakukan intubasi, kemudian diberikan start dengan ventilatory support. Nah, kemudian pasien ini tentu direncanakan untuk dilakukan intermittent hemodialysis ya, karena pasien ini juga dengan bleeding tendency ya, dari urinnya itu kateter ini setelah dipasang kemudian terjadi hematuri di sana dan dari sela-sela dari kateternya ada perdarahan. Kemudian juga dari insertion site CVC-nya itu juga terjadi perdarahan ya, yang untuk CDL-nya. Nah, kemudian pasien ini dimulai hemodialisis tanpa heparin karena tadi risiko bleedingnya. Kemudian dalam perjalanannya ya prosedur IHD-nya ini kemudian harus di stop karena pasiennya mengalami instabilitas dari hemodinamik. Ya, kebutuhan dari vasopresornya naik, tekanan darahnya tidak bisa naik, akhirnya diputuskan untuk intermittent heart disease-nya dihentikan dan kemudian di switch dengan CRRT. Nah, pasien ini karena menggunakan high dose vasopresor dan inotropik tentunya, kemudian pasien juga mengalami aritmi yang saat itu dengan sudah dilakukan terapi juga, ada bleeding tendency, maka pilihan CRRT-nya tentunya yang antikoagulannya bukan heparin ya, yang menggunakan lokal antikoagulan ya, yang dipilih adalah Citrate. Ini adalah setting awalnya pada saat itu dengan ultrafiltration rate-nya sekitar 100 ya, dan blood flow-nya juga 100 ml per menit. Nah, kalau kita bicara tentang pemilihan antikoagulan pada CRRT, tentunya pada kasus ini kan ada bleeding tendency ya, ada bleeding tendency. Ya, jadi kalau misalnya pasien itu dengan status koagulasi normal, tentunya kita bisa pilih apa saja sebenarnya ya. Tapi biasanya yang lebih mudah kita menggunakan unfractionated heparin ya. Nah, kemudian tapi kalau ada kecenderungan terjadi gangguan koagulasi atau sudah ada bleeding tendency, maka pilihannya sebenarnya ada tiga. Kita bisa menggunakan prostaglandin epoprostenol atau PGE1 atau sitrat, atau kalau dia plateletnya kurang dari 50.000, kemudian APTT-nya lebih dari 60 detik, INR-nya lebih dari 2 dan ada tanda-tanda di IC, ya maka kita bisa mempertimbangkan untuk tidak menggunakan antikoagulan. Ya. Dan tapi kalau dalam perjalanan itu klot gitu ya, misalnya dalam beberapa jam sudah klot, maka berarti dia harus menggunakan antikoagulan. Maka pilihannya ya tadi antara PGA1 atau kita menggunakan sitrat. Ya, dalam kasus ini kita menggunakan sitrat. Nah, ini secara umum kalau kita menggunakan CRRT dengan sitrat ya, itu eh, Citrate solution ini sebenarnya sebagai antikoagulan yang sifatnya dia itu sebenarnya hanya di lokal ya. Jadi ibaratnya dia hanya lokal di sirkuitnya saja. Ya, jadi tadi dikatakan bahwa dari sisi efikasi dia itu menyebabkan kalau kita menggunakan sitrat itu dia lebih terlokalize. Jadi umur dari filternya itu menjadi lebih panjang. Ya, tapi dari sisi keamanan ini yang juga harus kita perhatikan karena apa? Karena kalau kita menggunakan sitrat ya, kemudian sitratnya itu tinggi, maka sitrat ini kemudian akan mengikat kalsium dan kalau kalsiumnya itu rendah, maka juga bisa akan terjadi selain terjadi bleeding tendency di sistemik yang lebih berat, juga bisa menyebabkan gangguan-gangguan yang lain, irama jantung segala macam. Karena kalsium itu sebenarnya adalah suatu elektrolit yang sangat vital dibutuhkan untuk metabolisme tubuh gitu ya. Jadi di sini dari arterial line gitu ya, dari arteri ya, itu masuk sitrat ya. Sitrat dosisnya itu sekitar 3 sampai 4 milimol per liter blood flow ya. Kemudian targetnya yang ini kita menggunakan kalsium ya, targetnya adalah kalsium. Kalsiumnya harus cukup rendah gitu ya, supaya tidak terjadi clot gitu ya, karena kalsium itu adalah sebagai suatu faktor yang sangat penting untuk koagulasi ya. Tapi di dalam sirkuit ini diharapkan dia rendah sehingga tidak terjadi clot di sana ya. Nah, kemudian sebelum dia masuk ya ke sistemik, maka kalsium yang rendah tadi harus diganti. Supaya apa? Supaya dia tidak kalsiumnya ya lama-lama kalau dia kalsiumnya itu rendah masuk ke sistemik, lama-lama akan terjadi perdarahan sistemik. Nah, itu yang harus kita hindari, maka kemudian di sana diberikan kalsium ya. Sehingga target kalsium itu targetnya adalah sekitar 1,1 sampai 1,2. Nah, moodnya apa? Moodnya terserah. Itu kita bisa CVV HD atau CVV HDF gitu ya. Nah, ini adalah keuntungan kalau kita menggunakan sitrat dibandingkan heparin gitu ya. Keuntungannya apa? Ya tentunya risiko bleedingnya lebih rendah gitu ya. Kemudian eh, tadi filternya eh, sudah bisa lebih panjang ya. Kemudian kalau dia pada bleeding tendency dia lebih baik ya. Kemudian dia mencegah terjadinya mikrokoagulan formation. Ya. Nah, ini dibandingkan dengan heparin tentunya ini katakan lebih bagus ya. Beberapa evidence menyatakan seperti itu. Kemudian risiko untuk terjadinya HIT itu tentunya nggak ada ya kalau tidak seperti dengan heparin. Nah, tapi tentunya kita juga harus mempertimbangkan kalau kita pakai sitrat ya dibanding heparin, apa itu kerugiannya? Ya, tentunya monitoring yang kita butuhkan ya terutama untuk memonitor ionis kalsium, anion gap, pH itu menjadi sangat sering gitu ya karena kita harus close monitor di sini. Kemudian protokolnya menjadi lebih kompleks ya karena ini perlu yang biasanya menggunakan heparin ya kemudian menggunakan sitrat itu juga timnya harus mulai terlatih gitu ya. Kemudian resikonya apa? Resikonya bisa metabolic alkalosis, bisa acidosis gitu ya. Tergantung fungsi livernya seperti apa. Kemudian bisa juga terjadi hipokalsemia tadi memang kan sitrat itu akan mengikat kalsium dan tentunya dengan pemeriksaan-pemeriksaan tadi ya, kemudian kebutuhan penggantian kalsium, maka tentunya cost-nya itu bisa lebih tinggi. Dan tentunya eh, eh, dokter yang bekerja di sana juga harus berpengalaman, selain personel timnya juga harus paham tentang hal ini. Nah, oleh karena ini adalah setting awal ya pada pasien kami tadi ya. Ini menggunakan Fresenius Multi Filtrate Pro ya. kami menggunakan apa namanya mode CVVHD ya, karena pada saat itu kami menggunakan filter yang apa ya, IMC2 ya. Katakan IMC2 itu mempunyai kemampuan untuk molekul sedang ya, filtrasi molekul sedang termasuk IL6 segala macam itu katanya lebih baik gitu ya, dan antara mood CVVHD dan CVVHDF itu tidak terlalu berbeda, sehingga pada saat itu kami pertimbangkan untuk menggunakan CVVHD ya, karena untuk lebih menghemat ya, dialisatnya juga lebih hemat ya kalau kita menggunakan mood dari CVVHD karena kita tidak menggunakan replacement. Ya, kemudian kita gunakan antikoagulan regional citrate anticoagulation. Inisial settingnya seperti dialysate flow rate-nya sekitar 3000, citrate dose-nya itu sesuai dengan tadi, ya, kalsium replacement-nya 1,7 milimol per liter citrat, kemudian net ultrafiltration rate-nya itu ini 100 ml per jam, blood flow-nya kita set awalnya 100, kemudian bisa kita naikkan sampai 150. Kemudian pre-filter replacement-nya ya itu sekitar 75 ml per menit. Balance statusnya itu nanti diperkirakan dia akan minus sekitar 100 dalam waktu 1 jam. Pasien ini memang menggunakan vasopressor dan inotropic support yang sangat tinggi, dan kemudian ini back change intervalnya itu bisa kita lihat diatur di sana. Ya, ini adalah kalkulasi ya, jadi ini penting ya teman-teman, kalau menggunakan ini kita harus menggunakan kalkulasi ini, dan ini yang memang ya kita perlu berlatih gitu ya, perlu berlatih. Tapi kalau sudah 1-2 kali gitu, insya Allah ini akan lebih mudah karena rumus-rumus ini tentunya sudah ada ya di dalam beberapa protokol, tinggal kita pilih. Nah, ini yang kalkulasi dari sitratnya ya. Sitrat targetnya berapa dikalikan blood flow, maka kita akan ketemu itu ya, dan kemudian dalam 48 jam misalnya kita butuh berapa milimol sitrat. Nah, itu ya, nanti dari milimol sitrat itu kita sebenarnya butuh berapa bag gitu ya. Nah, itu yang nanti akan menentukan berapa sih sebenarnya cost-nya. Nah, ini untuk kalsium. Ya, jadi karena sitrat itu mengikat kalsium, maka tentunya sebelum balik ke sistemik harus di-replace. Nah, ini perhitungan dari replacement-nya. Oleh karena itu, dalam waktu 48 jam, ya, itu kira-kira kita waktu itu habis sekitar 150 ampul CA glukonas. Jadi, ya, memang ini yang menjadi hal-hal yang harus dipertimbangkan ya dari sisi cost ya. Jadi ini yang mungkin teman-teman nanti kita harus bicara ke BPJS segala macam ya di Indonesia, bagaimana ini coverage untuk kalau kita menggunakan citrate ya, tentunya pasti nanti ada indikasi-indikasi tertentu karena memang cost-nya pasti akan lebih mahal ya. Kemudian targetnya ya sudah ada seperti tadi ya. Jadi kalau apa yang harus dimonitor? Yang harus dimonitor itu adalah post filter ionized kalsium ya, antara 0,25 sampai 0,35. Kemudian sistemiknya itu harus lebih dari 0,9. Ya, jadi kalau post filternya itu rendah, sistemiknya harus tinggi gitu ya, harus normal. Nah, sitrat itu kita adjust kalau ionis kalsium ya di post filternya itu 0,25, dan apabila kurang kita naikkan, apabila lebih itu bisa kita turunkan. Jadi ini harus dimonitor. Nah, ini adalah setting, ini inisial setting pasien ini dengan high dose vasopressor waktu itu. Ini inisial settingnya seperti ini ya. Net ultrafiltration, dialysernya, ya, kalsium dose-nya yang setelah dihitung seperti itu ya, dan kemudian ini adalah monitoringnya ya. Jadi pre-filter ya itu tiap 4 sampai 6 jam ya. Targetnya tadi 0,35 ya. Kalau lebih ya sitratnya dinaikkan ya. Kalau kemudian kalau untuk sistemiknya tentunya normal ya, di atas 0,9 tadi ya. Kemudian ini penting untuk menghitung kalsium dan ionis kalsium rasio. Ya, jadi kalau ini nanti misalnya kalsiumnya itu eh, ini bisa kita gunakan apakah kita kelebihan sitrat ya atau memang metabolismenya itu terganggu gitu ya. Jadi ini penting ya, total kalsium dan ionis rasio ini kita cek. Kemudian pH dan HCO3. Ini makanya BGA itu menjadi mandatori. Kemudian plasma laktat ya, karena kalau itu meningkat ya kemungkinan bisa saja itu karena sitratnya itu ya itu metabolisme terganggu ya. Nah ini kita harus lihat ya kalau terjadi tadi ya apa citrate net overload atau ini apa citrate accumulation. Itu bedanya apa? Kalau akumulasi sitrat itu karena metabolismenya itu terganggu ya, sehingga sitrat itu masih masuk ke sirkulasi, kemudian terjadi eh, eh, s- sirkulasi sitrat kalsium kompleksnya di dalam darah itu tinggi. Diagnosisnya apa? Biasanya kalau sitrat accumulation itu metabolic acidosis pasiennya. Kemudian kita lihat tadi mengapa kita harus cek total kalsium dan ionized kalsium rasionya. Ya, kalau dia meningkat lebih dari 2,5, kemungkinan dia adalah sitrat accumulation. Ya. Nah, kemudian ya kalau sudah begini ya tentunya kita perlu apa namanya untuk eh, meningkatkan ya kalsiumnya. Kalsiumnya ditambah replacement dari kalsiumnya. Ya, kemudian tentunya ada beberapa hal yang bisa kita lakukan adalah menurunkan blood flow atau meningkatkan fluorid ya dari dialisatnya. Ya, atau kemudian ya kita mempertimbangkan untuk mengganti antikoagulannya ya karena di sini terjadi gangguan metabolisme dari sitrat. Ya, ini terjadi pada kasus-kasus di mana pasien bisa sepsis segala macam. Nah, kalau dia terjadi sitrat net overload ya, biasanya karena ekses sitrat ya, karena ini pemberiannya mungkin terlalu tinggi. Nah, di sini pada umumnya karena istilahnya bahan bakunya itu terlalu banyak gitu ya. Terus kemudian sehingga sitratnya banyak, tapi buffernya itu sebenarnya masih mampu ya. Sehingga efeknya apa? Karena sitrat itu dirubah jadi bikarbonat, maka bisa terjadi metabolic alkalosis. Dan kalau kita lihat Ca atau total Ca dan kalsium ionized-nya itu bisa kurang dari 2,5. Ya, yang paling sering sebenarnya adalah citrate net overload ini ya. Nah, caranya gimana? Mudah sebenarnya kalau ini citrate overload, ya maka kita bisa menurunkan blood flow. Ya, blood fluoridnya kita turunkan atau dialisat apa fluoridnya itu bisa kita naikkan. Ya, dengan begitu maka yang dibuang melalui efluen itu menjadi lebih banyak, gitu ya. Ya, jadi seperti itu ya. Nah, ini kalau pakai heparin ya sekarang heparin itu memang lebih mudah ya kalau dibandingkan dengan yang antikoagulannya heparin ya memang jauh gitu ya karena kalau kita menggunakan heparin ya mudah gitu ya. Ya patokannya cuma APTT saja dan tiap jam ya nanti kalau sudah stabil ya bisa 4 jam, bisa apa namanya tiap 12 jam ya. Ini yang menyebabkan pasien-pasien yang menggunakan CRT dengan heparin itu menjadi lebih murah ya dan lebih mudah. Tapi ya tadi ya kita harus ingat bahwa risiko ya kan keawetan dari apa filternya itu sebenarnya lebih baik menggunakan beberapa literatur mengatakan bahwa sebenarnya kalau cost itu ya tadi misalnya kok kalsiumnya banyak gitu ya sitratnya mahal tapi sebenarnya kalau dari sisi usia dari filternya itu sebenarnya kadang-kadang kalau pakai yang heparin 1 hari sudah harus ganti atau beberapa jam harus ganti tapi bakal pakai sitrat itu bisa 48 jam bisa efektif lah itu mahal mana sih sebenarnya itu perlu dikaji ulang dari beberapa ini adalah yang treatment protokolnya kalau kita menggunakan multi filtrate ini yang kita lakukan di sana ini yang kita monitor ya termasuk apa namanya ya tadi kalsium rasionya ini kita monitor ya. Jadi pada pasien ini monitoringnya seperti ini dalam 48 jam kita monitor semua kita monitor di sini ya. Nah Tadi dikatakan, kenapa ionized kalsium? Ionized kalsium itu ya sebenarnya adalah 45-50% dari total kalsium kita itu adalah ionized kalsium. Dan ini yang sebenarnya yang bebas ya, tidak terikat dengan albumin segala macam ya. Dan ini secara biologi ini adalah merupakan yang dibutuhkan oleh tubuh karena dia aktif. Fungsinya banyak ya, kita sudah paham targetnya ini. Ya. Kalau ini total kalsium, ya ini sebenarnya total kalsium itu termasuk tadi yang terionisasi, ya, kemudian yang terikat dengan protein dan yang kompleks, ya, sehingga range normalnya itu sebenarnya lebih tinggi, gitu ya. Nah, oleh karena itu sebenarnya kalau di pasien-pasien kritis yang kita cek adalah ionized kalsium. Ya, jadi kalau kita melihat ya di sini bahwa kita lihat ini tren dari blood gas-nya ya, ini yang kita lihat ya, ini kalsiumnya kita lihat dalam batas normal ya gitu ya, ionis kalsiumnya pada saat kita cek ya, kemudian pH-nya juga dalam itu pada saat pH-nya ini turun ya berarti kita hentikan ya, karena memang berarti syarat itu tidak banyak menolong dan pasien memang kecenderungannya lebih jelek ya. Jadi kalau pasien dengan CRRT tetap kemudian menjadi asidosis metabolik yang tidak terkompensasi, artinya kemungkinan dia prognosisnya jelek. Ini adalah apa namanya tren dari bun kreatininnya ya. Trennya memang tidak belum terlalu banyak ya. Kreatinin juga cukup ya, dari 13 turun itu pada hari pertama. Plateletnya turun ya antara 16 itu, tapi memang pada saat kita mulai CRRT itu sudah turun ya dibandingkan yang awal, dan penurunannya tidak signifikan sampai di bawah 50. Nah, ini kita lihat ya white blood cell-nya setelah CRRT sebenarnya turun ya, tapi kondisinya tidak membaik ya, artinya sebenarnya mungkin tidak membaik infeksinya ya, justru mungkin dia sudah mulai paralisis. HB-nya tidak berubah, yang menunjukkan tidak ada perdarahan yang aktif ya, kemudian elektrolitnya juga normal ya. Ini normal, ini harus hati-hati memang pasien-pasien dengan CRRT dengan renal replacement therapy harus kita pantau betul kaliumnya ya, karena kalau asidosisnya membaik kemudian ada yang terbuang juga, maka kemudian kalsium itu akan turun dan ini harus kita waspadai. Nah, ini sebagai clinical summary bahwa sitrat itu memang cocok ya kalau kita gunakan untuk pasien-pasien yang mempunyai risk bleeding gitu ya, dan karena dia tidak menyebabkan heparin-induced thrombocytopenia dan lain-lain, sehingga sitrat ini ada pasien-pasien yang dengan bleeding tendency itu sebenarnya cocok. Memang heparin itu lebih sederhana ya, lebih praktis ya pada resources limited setting gitu ya. Tapi ya memang pada kondisi-kondisi tertentu mungkin kita harus memikirkan menggunakan sitrat, dan penggunaan antikoagulan itu harus individualized ya, berdasarkan profil klinis pasien, bagaimana tempat kita, resourcesnya mampu apa tidak, dan tentunya ICU tim expertise-nya juga harus berpengalaman dalam menjalankan ini. Mungkin itu pengalaman kami yang bisa saya sampaikan. Moga-moga bisa menambah khasanah ya, wawasan kita dalam pengelola pasien-pasien kritis, dan mungkin nanti ke depannya ya sitrat ini mungkin bisa digunakan dengan segala kelebihannya, tapi tentunya juga harus dipikirkan bagaimana kendali. Kita kan ngomong kendali mutu ya, tapi jangan lupa kendali biayanya. Baik, itu yang mungkin bisa saya sampaikan. Terima kasih. Semoga bisa bermanfaat. Selamat siang.
Selamat siang, Dr. Bambang Puja. Terima kasih atas presentasinya yang sangat insightful ya, Dok ya, terkait dengan sitrat, case sharing, penggunaan CRRT dan juga sitrat dari pengalaman Dr. Bambang Puja. Baik, kita akan melanjutkan ke next topic ya, Dok. Mohon izin. So, we will next to the topic that will be presented by Dr. Robert for case sharing. So Dr. Robert, I will introduce you by bahasa Indonesia. Jadi dokter medical diploma engineering Robert Paul Meyer adalah seorang dokter yang juga memiliki gelar diploma di bidang teknik elektro. Keduanya diselesaikan di RWTH Aachen University, Jerman. Kemudian Dr. Robert Paul Meyer bergabung dengan Fresenius Medical Care pada tahun 1998. Awalnya beliau fokus pada penyakit gagal ginjal tahap akhir. Sejak 2001, beliau semakin mendalami terapi ekstrakorporeal untuk pasien perawatan intensif. Saat ini beliau sebagai Expert Director Acute Renal Care Therapy di Divisi Medical Information and Education Fresenius Medical Care Indonesia dan juga berfokus pada pengembangan aplikasi terapi ekstrakorporeal di ruang intensif, optimasi produk secara internal, serta peningkatan kompetensi klinisi yang menangani pasien cedera ginjal akut. So let's dive straight into today's topic. A warm virtual welcome to Dr. Robert Pulmeyer. Over to you.
Thank you, Mega. And so it should share.
It has shared.
You see the screen?
Yes.
That's nice. And then I shrink that window. That's nice. Okay. So just jumping in the topic, speaking about further clinical case situations, which I think are relevant when applying regional citrate anticoagulation. And the disclosure slide, you have seen it in Albert Fu's presentations, pretty much the same. This is a contribution to medical education. Decision-making at the end, at the bedside, obviously stays always with the treating physician. I have prepared a small list of topics to potentially go through. I think for time reasons, I'll have to likely stop after topic 4. I will address a bit on the kinetics of acid base and calcium changes. Just very briefly touch a topic of taking the systemic blood sample, and then touch citrate accumulation and clotting despite citrate very briefly. And I think that also addresses some of the questions, at least in part, I have seen in the chat. That is one key point I would like you to grasp from this session. The systemic effects on acid-base levels and also on calcium levels are usually slow, and this is as to be expected with CKRT. All of you who have applied CKRT know that it takes a day or two for substantially reaching a new level of urea or a new level of creatinine. And this slow kinetics on systemic concentration changes generally translates to other solutes as well. This is an example from the very, very early stage of rolling out regional citrate anticoagulation. Happened at a German hospital. For being used to their previous practice, they were starting the treatment with a higher blood flow than intended by protocol, 150 instead of 100 mils per minute. So the ratio of dialysate to blood flow was way off from the recommended starting value. And the key thing I want to show here with this case example is that it took a kind of full day for the alkalosis, metabolic alkalosis, to escalate to a point where they then reacted, changed to the recommended starting settings, and even went beyond to the other side. And that again, it then takes a period which you measure in days to correct the levels. Obviously, it's always easier in retrospect. One might have catched this steep increase already here and started here with
countermeasures, but that was in the very initial rollout. But future users can learn of this. If you see a steep trend, then you can assume that it likely will continue and you should react to it. But the good message is there is time to react to it. You just have to observe what's going on, and then you see the development in time. And this was shown by Dr. Bambang. In this case, we're talking here about a case of citrate net overload, which is benign and easy to fix. I don't have to go into much more details on that. And here a slide from a larger study on the protocol with the concentrated citrate solution with CVHD. And you see here, that's the key message to take from it. It takes 2 days kind of to normalize the acid-base status. This is the perfectly normal kinetics which you expect and at the end even want with CKRT to not have drastic quick changes in the patient. And very similarly, same situation, showing the kinetics on calcium levels. In this case, the patient was starting with a severe hypercalcemia. The ionized calcium was, I think, 1.77 at baseline at start of treatment. And so they started here with very, very low calcium substitution, way below the recommended starting value. And you see here, the middle curve shows the systemic ionized level. You see a clear dropping through the normal range to hypocalcemia values. And then they kind of drastically change to the maximum setting of the machine, got a rebound effect, and then after 2 days, it was stabilizing where it's supposed to be. And the settings in this phase are pretty close to the recommended starting value. So again, in retrospect, all is easier to judge on. One could have seen this steep drop and say, well, we are here in an okay range. Let's immediately switch back to the recommended starting value to have hopefully a stable level. And you could avoid these fluctuations here. Or even you might consider not to go that extreme here and start with something less somewhat closer to the recommended starting value, maybe 1.0 or so, because it's very powerful, a very powerful tool in correcting hypercalcemia. And skip that one. One tiny remark for the sampling of no, that's wrong, of the systemic ionized calcium. If you take, this is a real case I'd seen years ago, where they had decided to increase the calcium substitution drastically on the first day of treatment. And this was in reaction to these low values of systemic ionized calcium, which they measured. So we had here positive calcium balance, and here a negative, and here again a positive one. And if you see it, these two values probably are artifacts, because the blood sample for systemic blood was taken at the start of the extracorporeal circuit. And my assumption, my interpretation of this time course is that these are artifacts because of recirculation at the catheter tip. So if you go for a systemic value during citrate anticoagulation, I recommend against using this sampling site on the starting portion of the extracorporeal circuit, but really to go for some real systemic blood sample taken from the systemic circulation of the patient. In most cases, I would expect that there is an arterial access for monitoring blood gases anyhow present. Then this would be the location of choice for a systemic blood sample. And then the important point, citrate accumulation, and I did see a question on liver support in the chat, or liver function in the chat. This is data from Berlin, from the Citrate hospital, where they looked at a large patient case series, 3-year observational study, retrospective, but they included slightly above 1,000 patients. And they looked for citrate accumulation, and they were identifying kind of 3% of their patients. And citrate accumulation has a very bad prognosis. They had a high mortality for 28 days, but at the end, all the patients with citrate accumulation died during the ICU stay. I attribute this to citrate accumulation being more a biomarker for a severe breakdown of cellular metabolism, cellular energy metabolism. They had obviously significantly higher scores on the Apache-2 and also on the SUBS-2. As I said, citrate accumulation might simply signal the severity of the underlying disorders. This was combined with pre-existing liver dysfunction in only 1/3 of the affected patients. So the liver doesn't seem to be the crucial discriminant of when do we have a problem with citrate or not. But all of these patients had severe therapy-resistant septic shock, multi-organ dysfunctions, and severe lactic acidosis. So if you have a severe sepsis problem, lactic acidosis, tissue hypoperfusion, then there's a higher likelihood of a problem with citrate accumulation. This obviously can go hand in hand with some severe liver problem. For the time pattern, you can also see from their study, they took as time 0 the point of clinical diagnosis of citrate accumulation. And if you look then back to the phase before, the first signal they can clinically perceive is a otherwise not explained drop in ionized calcium levels and the need to increase calcium substitution. This is something they could see kind of 36 hours before. Then this was followed by rising lactate levels, and then at the end, dropping bicarbonate levels. So they conclude that hypocalcemia with sustained increase of calcium substitution by the dialysis device, as well as a parallel continuous increase of lactate concentration, was the first clinically recognizable sign of imminent citrate accumulation. So from this experience, I would recommend to have an eye on these lab values to get an early grasp of such a situation. They were also looking 3 years later in a second paper on what can be predictive for such citrate accumulation problem. And they looked at it for single lactate levels, either at baseline or during the early phase of the treatment. But the conclusions taken from a single lactate measurement are really limited, which can be drawn. So they arrived at a point to look for the kinetics of lactate. So if a patient has a low baseline lactate level, low meaning below 4 millimole per liter, then then you have a problem when lactate starts rising during the treatment. But if the patient is starting with a high lactate level, then the problem is when it doesn't drop. And the important point here is that observing the kinetics over time is really helpful in judging what's going on. And this applies specifically here also to lactate kinetics. So not just look on the last measured lactate level, but also look a bit back on the timeline, how it has developed over time. And adding to the point of liver is not that big a problem. There's an already quite old, 2 decades old, meanwhile, paper from China, which has been clearly showing that severe hypoxemia, which was an arterial oxygen level, partial pressure below 60 millimeter mercury, this was more pronounced with acidosis and a drop in ionized calcium level. So there was more trouble concerning this clinical picture with citrate metabolism than the more slightly affected levels compared to the control group when the patient had a liver dysfunction. So really looking on what's going on with cellular energy metabolism, oxidative metabolism in the cells. And this is, if you look on it, you have here in this blue-grayish color the intracellular space, and in white the mitochondria. And you see that citrate enters the mitochondrium and then is degraded in the Krebs cycle, and the hydrogen is transferred to the coenzyme NAD+, and then finally metabolized in the respiratory chain to water at the end. And so we need both the Krebs cycle and the respiratory chain to metabolize citrate efficiently. If there's a problem with these very basic biochemical pathways, then we can see the clinical picture of citrate accumulation. And kind of a slight glimpse on a device support. We pick up the high need for calcium substitution to present a note on the screen to trigger the thinking on citrate accumulation. And this is coming back to the table published by Antoine Schneider, an example of the more severe problem of citrate accumulation. And the, I think, last topic I will briefly touch on is I want the clogging. I want this one. Clotting despite citrate anticoagulation. This can be seen in rare cases, and it may be a symptom of HIT type 2. This case report was published here by Dr. Lehner from Austria, where they had a drop of platelets during the treatment, which they first attributed to sepsis. Then they observed premature filter clotting, and then realized it was a HIT type 2 based on the 4T score. And also they were able to demonstrate presence of IgG antibodies against the heparin PF4 complex. And then they changed the thrombosis prophylaxis from the low molecular weight heparin to Orgaran, and the problem then got resolved. So there is some activation of the systemic clotting system leading to thrombin activation. This can manifest as clotting in the extracorporeal circuit. And similar observations have again been published by Dr. Kachinov from the Charity in Berlin. He looked again at his large patient series and did see the problem in 12 out of close to 1,200 patients. So 1%. They usually then add agatroban for some systemic anticoagulation, and this helps increasing the filter lifetime again significantly. An important subgroup is HIT type 2, where this improvement was very, very prominent with agratoban, but also in the other group where they could not prove presence of HIT type 2. They did see an improvement of filter patency by adding some agratoban. So the two things to draw from this: an undetected HIT type 2 or other causes of thrombin activation may exist in patients with recurrent early filter clotting despite strict adherence to the citrate protocol. If such a problem is occurring with frequent filter clotting, it's recommended to screen for HIT type 2. And if feasible from the patient situation, adding a thrombin inhibitor like agratoban is one, could be an option. Again, decision at the bedside by the treating physician. And concerning the mechanism of activity of citrate, also that was asked in the chat. I locate the mechanism of the citrate activity mostly by withdrawing calcium from the protein domain of the vitamin K dependent clotting factors. They share a so-called GLA domain, and I locate the mechanism of citrate anticoagulation likely there. There's an important thing. Prothrombin has this part, so I would think that citrate helps in blocking activation of prothrombin to thrombin. But once thrombin has been generated, thrombin doesn't have this protein part any longer. Then I don't expect any inhibition of the later downstream parts of the clotting cascade. So if there is activation of thrombin before, either HIT type 2 or otherwise systemically, I think that there are good reasons to assume that citrate alone might not block the clotting pathways, the various parts of the clotting pathways sufficiently, and addition of a further anticoagulant could complement the anticoagulation effect. I think that is what I had chosen to present in the available time here. And Mega, if that fits for you, I would open it to any questions if there is still time.
Thank you so much, Dr. Robert, for the comprehensive presentations. So the next agenda is Q&A. And we have several questions on the Q&A box, and also several questions that already answered by Dr. Albert Fu. So I think I will read one. The last one is, hi, I'm Daddy. I wanna ask about which is the most benefit, whether we use citrate or heparin as anticoagulant in CVVHD mode only or in hybrid combination CVVHD mode. Example combination with hemoperfusion, which is using Jaffron filter, and what is explanation for such reasons? I think what if using a anticoagulant citrate or heparin and a combination with Jaffron filter, this is absorber, if I'm not mistaken.
Yeah, I have no knowledge about the actual use of the Jaffron adsorber with citrate anticoagulation, but I think there's a similar product also on the market to Jaffron, at least roughly comparable, which is the cytosorb filter. And for the cytosorb filter, I think there is experience, and I think it works in combination. I'm pretty sure there's literature on that combination. For the actual combination with the Jaffron filter, I'm not aware of any data. Albert, do you have anything in mind for Jaffron?
No, Jeff, which I was approached normally from chronic conditions, they like using that. Yeah, but for acute, I think it's also questionable how much additional benefit can be guaranteed to enhance cytokine removal for sepsis patient and so on. But if they want to use, if you confirm there are cytosorb, a similar case used, I believe they can use similarly for Jaffron as well, in theory. Yeah.
Yeah,
Okay.
that would be plausible, but it's not officially released to my knowledge. But we have a release for the cytosorb.
So if there are any questions, perhaps the participants can raise hand if they want to have a question directly. Okay. All right. Thank you so much. Yeah.
You're going for the question by Didi, which just popped in.
Yeah.
Okay. I think the simple answer is yes, you can. There's a paper 2004 by Dr. Morgera where he has 3 groups, only citrate, only heparin, and there's a third group with low-dose heparin, I think mostly for thrombosis prophylaxis, combined with the unchanged citrate protocol. This is absolutely not a problem to combine it that way.
Okay, so the daddy one has another question. Can we combine between heparin low dosage and citrate as anticoagulant in CVVHD mode in CKRT?
Yeah, and the answer is yes.
And how about the monitoring examinations for citrate usage? So I think it's already mentioned.
Albert, I think you had that in your talk.
Yeah, not too much this time, but I addressed a similar question like this. Also, the first question answered already in the list answered. So generally, citrate use, how to monitor, it depends on what we are going to monitor. So if we are talking about efficacy of anticoagulation, then we need to monitor post-filter ionized calcium level. Commonly, it is expected in the range of 0.3. And if that is not the case, we need to adjust the citrate dose. In the protocol, it will very well define 0.1, 0.2 millimole per liter will be suggested according to how far this is deviating. But the citrate use is also impacting patient ionized calcium level, so that is more to be adjusted by the systemic to monitor systemic ionized calcium, reflecting patient safety. And if that is not in the normal range, then calcium infusion rates, that dose should be adjusted. Yeah, so these are the 2 major ionized calcium and reflecting different things. And also to adjust them, one is the citrate dose, the other is calcium infusion dose. So two distinct channels and approach.
Okay. Thank you so much, Dr. Albert Fu and Dr. Robert, for answering the questions. So I think we ran out of time for this webinar. Perhaps if there are any, I'm sorry, apabila Bapak dokter-dokter sekalian yang partisipan yang telah memiliki pertanyaan lainnya bisa kontak melalui grup WhatsApp kami. Okay, so for Dr. Albert Fu and Dr. Robert Pulmeyer, also for Dr. Bambang Pujo, thank you so much for the time, for the opportunity to this webinar to sharing knowledge about regional citrate therapy, also the case sharing, also the challenge that we will be perhaps facing when we do multifiltrate but also regional citrate antitherapy. So I will have a conclusion and bahasa. Jadi kesimpulan atau ringkasan dari webinar kali ini yang bisa kita sederhanakan yaitu RCA merupakan regional citrate antikoagulan merupakan metode antikoagulasi pilihan untuk CRRT yang telah direkomendasikan oleh KDIGO sebagai lini pertama untuk pasien akut yang memiliki tanpa kontraindikasi sitrat dengan resiko pendarahan lebih rendah dan potensi filter lebih lama dibandingkan heparin. Kemudian sitrat pekat mungkin memberikan keunggulan. Studinya masih terbatas menunjukkan protokol dengan sitrat pekat, misalnya 136 milimol per liter dapat memperpanjang masa pakai filter dan meningkatkan klarifikasi solut meski beresiko alkalosis. Kemudian pemilihan protokol harus dipertimbangkan efikasi dan keamanan. Pilihan antara sitrat pekat atau encer harus disesuaikan dengan tujuan klinis, misalnya durasi filter, stabilitas elektrolit, faktor pasien, misalnya pasien sedang memiliki risiko komplikasi metabolik. And we would like to wrap up this webinar for Dr. Albert and Dr. Robert and also Dr. Bambang Pujo. Terima kasih kepada bapak-bapak yang bapak dan ibu partisipan yang telah menghadiri webinar kali ini. Semoga ilmu yang diberikan atau pengetahuan yang telah di-sharing oleh praktisi expert dapat berguna di klinis sehari-hari. And like to say thank you for all and see you in another change.
Thank you so much. Thank you, everyone. Thank you, Mega.
Thank you so much, Dr. Albert.
Thank you very much.
Terima kasih Dr. Bambang Pujo atas waktunya.